Broadcast is now starting. All attendees are in listen-only mode.
Hi, welcome to everybody who has joined this webinar, Key Changes in the Healthcare Value Chain. Let me first introduce myself. My name is Sarah Preston. I'm the Programme Manager for this programme today, and I'm joined by James Barlow, a Professor at Imperial College Business School. During the next 20 to 30 minutes of the webinar, please feel free to ask any questions using the question box, and James will try and answer as many as possible at the end. I'm now going to hand over to James, who will introduce himself.
Hello, and welcome everybody to the webinar. Just to give you a little bit of background about myself, I'm a professor of technology and innovation management in the business school, and most of my work focuses on innovation in healthcare. And I've been working for over 20 years looking at the challenges of getting innovations adopted and spread and implemented into healthcare systems around the world. A lot of my work involves consulting with industry and policymakers, and I sit on various advisory boards for companies and government bodies. So I have quite a good insight into trends and how things are shaping up in a number of different countries around the world. What I'm going to do today is I just need to advance the slide. Okay. Sorry, I'm just trying to advance the slide here. Okay. Right. Okay. Apologies for that. Just had a slight technical problem. What I want to do today is to focus on why we need innovation to cope with global challenges in health systems. All health systems around the world are facing huge pressures, which need them to respond with new ways of doing things. So we need to think about what kind of innovations are needed and what that means for the value chain within the healthcare system, the links between different players, different incumbent players, and potentially new players coming into the system. What I like to do first is to talk about the global challenges, then say something about healthcare innovation, and in particular the fact that it's not just technology. I then want to turn to this question of disruptive innovation. How can we use disruptive thinking and disruptive innovation to move from a 20th century to 21st century model of healthcare, and then wind up thinking about implications for the key players. One of the key challenges, of course, for health systems, and this isn't just the developed countries now, this is developing countries too, is rising expenditure on healthcare. And over the last 20 years or so, we've risen from around 8.5% of global GDP being spent on health to around about 10% now. So it's inexorably rising, faster in some countries, such as the US, than others. But nevertheless, there is a continuous pressure on the world's economies from an increasing amount of money spent on healthcare. And of course, part of this is due to the aging population. There are over the next 35 years, there'll be something like an extra billion people aged over 60 in the world, and 300 million people aged over 80. And of course, that's accompanied by a whole range of different medical conditions and social needs as well, which play out differently in different countries, but nevertheless are huge challenges for healthcare systems. Another big challenge is obesity, the rising incidence of obesity. Around 30% of the world's population is currently overweight. And of course, there are a wide range of associated conditions with obesity, which again are bearing down on healthcare demand and healthcare systems. This is not just a developed country problem. Places like India and China are also seeing major challenges around diabetes, for example, due to the rising incidence of obesity. Globally, there's therefore an epidemiological transition taking place. We're seeing a shift over the long term between infectious diseases, what some people call diseases of poverty, to long-term chronic conditions such as diabetes and heart failure, but also mental health as well as a major problem. And this is taking place right around the world now. So there are a number of countries which have got the double burden of a population with suffering from the infectious diseases, but also a population suffering from long-term chronic conditions. And the important thing about this epidemiological transition is that it has implications for how we think about healthcare, how we organize health systems. We need to move much more towards a preventative model of care rather than one which is just reactive and treating people when they get ill. And then finally, there are the big unknowns, or the known unknowns, things we know are problems in health systems, but we don't quite know how they're going to pan out in the future. One of these is antimicrobial resistance, so the rise of superbugs resistant to antibiotics, and currently around 800,000 people a year die of globally of resistance to antibiotics. That could rise to 10 million deaths per year by 2050, costing around $100 trillion cumulatively between now and 2050 for the world's health systems. By the way, we spend about 10 trillion per year on healthcare globally. So major challenge. We don't know how it's going to pan out. The other big known unknown is climate change. Climate change resulting in heat waves and excess mortality due to heat waves. The spread of vector-based diseases like dengue fever and malaria to areas which had previously eradicated them, but also poor air quality and pollution. And we've all seen this week the problems in Delhi around air quality. So health systems around the world are facing major challenges. We have to deliver care, but we have to deliver care in the face of rising demand from an aging population, from changing patterns of epidemiology, and we've got to do it in a way that's affordable to economies. So the real challenge for developed countries' health systems, so those in Europe and North America, Japan, Australasia, and so on, are how we maintain access to high quality healthcare, which we more or less have at the moment, but do it in a way that doesn't result in escalating costs and rising demand. I should say also we have significant resource constraints in terms of labour shortages in many developed countries' health systems. We shouldn't neglect the countries with more rudimentary and emerging and developing health systems, particularly in Africa and South Asia. And the problems here are slightly different, perhaps, in the sense that they need to deliver access to as much of the population as possible, and access to good quality services, which at the moment don't exist, but also do that in the face of shortages in healthcare workers, shortages in money, and access to technology and so on. And the chart here simply shows the relative size of the health worker shortage in different countries around the world. And you can see that even though we have problems in Europe and North America, there are major shortages of health workers in some parts of the world. And I'll come back to this in a moment, but that's driving innovative thinking, which actually has implications for how we think about delivering healthcare here in an advanced, developed health system. So that's a little bit about the global healthcare challenges. And I now just want to turn to innovation in healthcare and think about what innovation means in healthcare and in the healthcare context, and what kinds of innovation we need to cope with some of these 21st century challenges. And typically when people think of the word innovation, they hear the word innovation, and the received wisdom tends to be that it's things, it's products, devices, new gadgets, perhaps that Tesla car there on the left. Sometimes people think of it in terms of services or new business models in retailing, or perhaps airlines, low-cost airlines. And I've put People Express down there and Laker Airways for those of you who remember. It wasn't all Ryanair and EasyJet who changed the face of the world's airline industry. There've been business model innovations in airlines for many years. So the received wisdom is that usually, however, it's seen in terms of new products, and healthcare is not dissimilar. People tend to view innovation in healthcare in terms of new technology, new drugs, devices. They think of words like AI, data science, and so on, and they usually see it as something that's delivered in hospitals by doctors. And I was at a conference yesterday on what the built environment, the built infrastructure will look like in 100 years' time. And there was some discussion about healthcare, and everybody universally in that conference saw it in terms of hospitals and high-tech gadgets and devices. Now that's fine, but there is a growing realization that more technology is not necessarily a good thing in healthcare. Yes, of course, we all want the best drugs, the best equipment, if we fall ill, but it's now widely recognized that there's a cost inflation problem associated with technological innovation. And in the US, for example, health economists have estimated that as much as anything between a quarter and half the entire increase in health spending in the US from the 1960s onwards has been due to the adoption of new technological innovations. And the reason for this is that they allow you to do new things, treat more people who you previously couldn't treat, which is fine, of course, if you're a patient, but it adds cost to the system, or you detect problems which previously weren't detected, which then have to be tackled by the health system. So new technology is a double-edged sword for health systems. It's potentially good in terms of delivering better quality care and better outcomes, but it costs money. Many commentators and researchers now recognize that while new devices and drugs and apps and so on are very important, the real gains for improving health services and health systems are going to be achieved by rethinking how we organize care and putting in place process innovations and business model innovations. And what this chart shows is, it's from a report by the Health Foundation a few years ago. It essentially is saying that over time, there are different layers of innovation, organizational innovation we can bring into the health system. We can deal with procurement and managing the workforce better. We can redesign clinical pathways. We can shift attention towards from hospitals towards primary care and prevention, and we can introduce models to try and incentivize behavior change and get people to eat more healthy food or walk more. And all those areas are really key areas of innovation, which may be supported by technology, by apps, by new monitoring devices and so on, but they are essentially organizational and process innovations. And they are more or less easy to bring in, and will have a greater or lesser impact over time. But essentially, the point is here that it's not all about technology. Technology supports organizational change. And that essentially is what health systems are beginning to now realize. We don't need to just load more and more gadgets and devices onto those systems and somehow miraculously expect them to improve. And a lot of the discussion now is really around disruption, disruptive models of healthcare. If we're going to move towards a truly 21st century paradigm for healthcare, we're going to have to find ways of disrupting old models. Essentially, the models that we have today are ones that have been with us for 200 years. We treat people when they get ill. They go to a building, possibly a hospital. They're seen by an expensive healthcare professional with a lot of expensive equipment, and then they go home again. And we need to break that model to move it to something that is cheaper, simpler, but effective and good enough, and still delivers high quality outcomes. So how do we do that? How do we introduce disruption into the healthcare system? And this slide really is trying to say something about what it is we wish to achieve. And it outlines some of the key characteristics of healthcare as currently practiced on the left, and some of the characteristics of what are widely recognized as a desirable and achievable model of care. So we need, for example, to move from a clinician-centered model to one which is patient-centered. We need to move towards a much more integrated, collaborative set of institutions rather than one that's fragmented and essentially siloed. Patients have to be active participants in their care rather than passive recipients, and so on. More isn't necessarily better, the last bullet point there. At the moment, typically, we deal with challenges by bit of reorganization and more money. So constant demands for greater budgets for the National Health Service, for example, a bit of reorganization here and there, rather than really thinking about how we focus on value, how we co-design new solutions, how we try out new ideas and scale them up if necessary. So that's the desirable goal, I think. It's how we move towards this 21st century model whilst meeting the challenges I outlined at the beginning, but also doing it in a way that controls costs for everybody. And there's been a lot of discussion around disruptive innovation over the last 20 years, but there's also a lot of confusion about the term disruptive innovation. It was first coined by Clayton Christensen back in the early 1990s, but it's often confused with radical innovation, with paradigm shifts, with sort of high-tech change. I've just come from the Francis Crick Institute, just before I came here to do the seminar, one of the world's largest life sciences research centres, incredibly cutting-edge research. And some of that innovation going on there will certainly disrupt health systems, but it's not necessarily what we might call disruptive innovation. And disruptive innovation is essentially about this. It's about cutting out over-specification in health systems. The argument that Christensen and others have made is that over the years we've had constant incremental change, incremental innovation occurring in health systems and other parts of our lives as well. And usually that adds cost to the system. So we have very advanced, technologically advanced health systems, which are very expensive and delivering a particular model of care. And we need to cut out some of that, some of those functions which are delivered in hospitals and find new ways of delivering that care outside hospitals with new kinds of healthcare professional. So the Swiss Army penknife, which had been subject to incremental innovation over the last 40 years, might end up looking like that. And we want to get away from that and move to something simpler and more usable. And there are plenty of examples of disruptive thinking, disruptive innovation in health sector now. People rethinking, for example, how we deliver the emergency phase of stroke care, which at the moment is all about sending people who have a stroke to a hospital, putting them into an incredibly expensive bit of equipment to scan their brains with an extremely expensive team of experts to deliver thrombolytic drugs if necessary, with variable outcomes, but doing it through a combination of technological innovation, scanning people in the back of an ambulance or in the street, and then possibly delivering that drug out in the field. So getting that drug to people much faster, but rethinking the pathway for emergency stroke care, for example. There's also a lot of work that's gone on around redefining the notion of a hospital, thinking of hospitals much more in terms of specialized services as part of a wider integrated network, but also engaging in a huge amount of process innovation, lean thinking to get patients through the hospital faster, and redesigning the built infrastructure in ways that you can cut out a lot of the expensive, actually unnecessary elements of a hospital design and doing it in a cheaper, simpler way. But again, part of a wider integrated network. And then lastly, there's a lot of interest in disrupting healthcare by using existing technology in new ways. And I said that in developing parts of the world where there are rudimentary health systems, resource-poor health systems, a lot of very interesting innovations coming out of those parts of the world around the use of mobile phones to deliver health services and other types of service like banking to people who don't have access to them. And some of those ideas beginning to percolate back to the advanced health systems as possible innovations. The same with the hospital example I gave you just now. A lot of that is emanating from India and some other countries and now being taken up in developed countries' health systems. All these innovations are beginning to result in a restructuring of the way healthcare is delivered in terms of its location and who delivers it. So we're seeing on the one hand care being pulled out of traditional general hospitals, traditional inpatient hospital care, out into the community in specialized centres or into the home itself using telehealth and telemedicine, but also shifting skills away from expensive, high-cost specialists to nurse practitioners, GPs, and more self-care out in the community. But on the other hand, services also being concentrated in tertiary care and university hospital centres. So the stroke services I mentioned just now being reconcentrated into hyperacute stroke centres where they can deliver the best care once people have been dealt with out in the field. So all this is having a big impact on not only on the way we organise services, but also the built infrastructure for healthcare, and the kinds of healthcare professional that we need. Of course, it's all very slow. Innovation is never easy in healthcare. It's difficult because healthcare systems are immensely complex institutionally. Many institutions, different vested interests, lots of incumbent players, a lot of regulation. So you do something in one part of the system and it has an unexpected effect somewhere else perhaps, not necessarily immediately, but with a time lag. And we know, any of you who are listening who are involved in trying to get innovations adopted knows that it's immensely difficult and takes a long time. And there's also path dependency in health systems. We can't just tear up the National Health Service in the UK, for example, or any health system in a developed country and start again. And that's perhaps the advantage that you find in countries with less highly developed health systems. They can, to some extent, bring new ideas in more easily than we can here. So what does all this mean for key players and the value chain? How does this landscape I've just painted impact on incumbent partners and where do the new players fit in? And of course, there's a lot of interest in the role of new players in disrupting existing models of care and value chains in healthcare. The global tech giants certainly see healthcare as potentially huge and valuable space to move in, one that's just simply too big to ignore. Even Uber there is playing in healthcare, looking at patient transport to and from, for elderly people, for example, to and from their appointments. But of course, even the global tech giants find healthcare difficult, and the big picture, or the healthcare system as a whole, is simply too big for even the big tech giants to swallow all at once. So you remember, just recall the complexity slide a couple of slides back. It's incredibly complex. They don't understand it fully. They want to be involved. And at the moment, they're beginning to break off different segments and play in those different market segments. So Apple with consumer products, Microsoft with analytics, and so on. Alibaba, not often talked about in relation to health, but certainly great interest in pharmacy, retail, and back office support services. So they're all beginning to dabble in healthcare, to think about where they fit. But they all have different strengths and weaknesses as well. And it's likely that they will continue in this sort of vein for some time, I think, trying out and experimenting, working out where their strengths and weaknesses lie, looking at what the potential risks are for them, and beginning to learn how best to engage in healthcare. But nevertheless, they are still very, very busy investing in acquiring startups and other companies from right around the health sector. And you won't be able to read the detail on the slide, but you can look at the web link when you get the slides. But you can see from that the big global tech giants are busy creating their own sort of healthcare ecosystems around the acquisition of various startups and engaging in joint ventures and so on. And tech is sexy. Even incumbent healthcare providers, relatively recent players in healthcare data, for example, which a few years ago would have called them healthcare companies, are now beginning to rebrand themselves as tech companies. Tech is sexy when it comes to potential investment. So what's the future direction of travel? Will we achieve this 21st century model of care? What's it going to look like in the future in 10, 15 years' time? And the slide here really shows how we may move from the current model, which is essentially an ecosystem of different silos, connected by transactions which are essentially business-to-business transactions between healthcare providers, funders, government policy makers and institutions, and the suppliers of drugs, devices, and so on, with relatively passive patients. We may move towards one where you've got this sort of modular ecosystem around multi-sector markets, markets that are essentially focused around delivering care services, secondly, providing diagnostics and therapeutics, thirdly, providing finance, fourthly, providing data platforms and support, and then fifthly, wellness technology and health management. And those will be driven partly by the global tech companies, but also by the incumbent players themselves. And within that model, we'll move towards a situation where consumers of healthcare are much more engaged and involved within their healthcare system that they live under. So that's the vision, anyway, of many commentators and companies. And of course, some of that will come true. But of course, the reality will be much more nuanced. Just go back to that complexity slide. You're never starting from zero base. You're starting from a complex health system. So how that particular health system in a given country is configured, how the institutions relate to each other, how it's financed and so on, what its particular challenges are, will shape how that previous vision on the right there will play out, I think. And of course, it'll be influenced by the incumbent players themselves and how they respond. The existing big pharma, big meg tech companies and healthcare providers and so on, how will they respond to this? So the reality, I think, will contain elements of this slide on the right there, but shaped very much by the healthcare system within which it's being implemented. So finally, really, I just want to end by leaving you with a series of open questions for discussion. I think there are big questions around regulators and current funders of health services and current providers of health services. To what extent will they play ball? To what extent will they drive or inhibit change? How will the existing pharma and medtech players engage with the global tech giants I've just outlined? Will there be true disruption? Will there be new organizational structures and business models emerging of the kind that I outlined when I was talking about the need for organizational change? Or will it just be adding cost to the system, creating more demand for services? And of course, what about us as patients or consumers? What does it mean for us? How will we respond? What does it mean for equity and access? Will some people have access to the new services and others won't? And then finally, what about the resource-poor health systems? Will they be cut out of these new global tech-driven models, or will they be able to embrace them? So a lot of open questions there. Perhaps we can come back to that, perhaps in the discussion maybe. And lastly, just want to wind up by just saying that some of these questions are things we're going to be exploring in our next Executive Health Innovation Management Program, which is starting next February. All the points I've talked about today are themes that will come up within that program, which is in its third iteration now. We've run it twice before, attracting participants from across the health sector and across different countries. So I'll leave you with the questions and look forward to hearing from any of your feedback. And thank you very much for listening.
Brill, thank you. We do have one question in already, so I'm just going to ask you this one. Could you elaborate on prevention? Do you have any examples of healthcare systems that have managed to implement effective prevention programs?
I think there is certainly a lot more discussion around what a health system that truly focuses on prevention looks like. In the 20 or more years I've been working on healthcare, certainly in the UK, the talk has shifted from simply seeing prevention as something we need to do and a good idea, to real initiatives being put in place, whether they're to do with behaviour change and obesity, or exercise, some of which is supported by technology. There are very real problems in getting those prevention models put in place because we have fragmented health systems. So, it's reliant on thinking about who pays for what within the prevention service. Is it essentially a primary care question? Is it something to do with acute care? What's the role of technology companies here? So the fragmentation of health systems around the world means that it's actually quite difficult to get these complex innovations which embrace all parts of the health system put in place. But I think we are getting there with prevention. Technology is helping. I think the other big change for me in the time I've been looking at this is the explosion of wellness apps and bits of equipment like Fitbits and so on, Apple iWatches, which over time I think will shift people's approach to their health and certainly incentivize some behavior change. So I think it's happening. It's getting there, but it's a slow process.
Brill. Got another question here for you. Thanks for the presentation. Lots of food for thought. Could you please talk a bit more about your current topic research focus and how you approach them?
My own research.
Yeah.
I suppose one of the most interesting projects I've been involved in recently is actually around innovation in malaria control. And there's a very large Bill and Melinda Gates funded project led from Imperial College around the creation of genetically modified mosquitoes to eradicate malaria. And for the last 4 years, I've been involved in looking at the problems of getting that technology adopted into practice. And we've been looking at a particular country in Africa as one of the trial sites. And it's been a fascinating journey looking at very advanced medical technology or life science technology and a very resource-poor health system, and what the challenges of adoption are around this very advanced technology. I've also done a lot of work over the years on remote monitoring of people, so telehealth, telecare, particularly around aging. And I'm currently on the advisory board for a large Canadian research program on aging technology. So that's putting in place and developing technologies for people with dementia and multiple comorbidities and disability and so on. Fascinating work. But my big lesson, I think, in all this is it's not the technology that's the challenge. We can do the technology, we can do the science, we can develop the drugs, the devices with enough resource put in place. But it's getting them taken up that's the real problem around the world. And every country has the same problems, I think, which are around the complexity of health systems and who pays for what, and the existence of fragmented silos within health systems. So the technology is fine if we can get it taken up.
Great. So this one's actually about the content of the program, and someone's asked that they saw on the website for the Health Innovation Program that there will be an executive challenge. Can you explain a little bit more about this part of the course?
Yes, this is all about your own particular challenge. And what we've done in the past is to get the participants in the program to, before the course starts, to think about a particular management or innovation challenge that they've got. And then we give them a bit of coaching initially. So they come on the course with a particular problem. And during the three modules of the course, we work through the challenge collectively. So they're learning from other participants in the course who come from perhaps different healthcare system backgrounds, different experiences, and with our guest speakers, everybody tackles their own particular executive challenge, so that by the end of module 3, they've at least got some idea of a way forward. So it's tailored to your own particular needs.
Great. So one more we've got here. Disruptive innovation is slow. What is made to reduce the patient's flow and expenses? Do you think an education program or a life coach may be helpful? The health problems start most of the time at home. How the people live in their housing and in health and safety.
Yes, I completely agree. I think we have to get individuals more involved in their own care, more aware of their own care, and I think self-care is a fundamental part of the of future models of care. People shouldn't default to necessarily going to the GP and asking for a new drug. Most healthcare is actually delivered out in the community or in our own homes, and we diagnose the problem ourselves often and go to the pharmacy. And we need more of that. And that's very much what the disruptive innovation model is about. It's about taking some demand out of the system and out of the expensive parts of the system, where you're delivering care in hospitals, and you're treating people, and taking it into the community, into the home, making us more responsible for our own care, giving people support, whether it's through coaching, or through apps and other technologies. And again, all that has been around a long time as an idea, and it's now coming to fruition to some extent. Many apps are being tried out. I don't just mean the millions of apps that people try once and never used. There are real trials going on now with health apps to get people to coach, give people coaching and help them change their behaviour. So I think, as I said in one of those slides, most of the change and most of the way of tackling the challenges of healthcare is going to be due to organisational change and rethinking how we deliver services and how we bring patients more centrally into the decisions about care.
Brilliant. This is another one about the content and the faculty. Someone has asked, how are the sessions linked for the Executive Health Innovation Management Programme? Considering that these modules are in different countries, will it be the same faculty?
There is some constancy through the programme. I and a colleague from Copenhagen Business School have overall control over the whole programme. What we've been designing over the last few months is hopefully a fairly seamless transition from module to module, so that in the first one in London, it's very much around the big picture. It's about getting everybody up to speed around what the challenges are, learning something about what the innovation solutions are, And we have to do this because people on the course come from different backgrounds. Some come from the supply side, from pharma or medtech. Some will come from healthcare providers such as hospitals. Some might come from finance, the finance side. So and they come from different countries. So week one is about getting people up to speed, looking at people's executive challenges. Then week two is essentially drilling down into those into what we discussed in week one in more detail. Looking at some specific aspects of innovation and innovation management, and then week three is pulling back again slightly and thinking more about some more generic management questions around leadership and managing innovation projects, entrepreneurship in organizations, and how you stimulate innovation within organizations. So we're trying to create a sort of seamless flow through the three modules, and there'll be common threads running through all of them. One of which will be the executive challenge. So you come back to that in each module, and be refining your ideas and the solutions you come up with.
Great. We've just got time for one last question, and it's a political question, so I hope you're ready. Someone has asked, I know this is more of a political question, but do you think having politicians such as Trump and Bolsonaro in Brazil that don't care about climate change might have a lasting effect on health innovation spending, particularly in countries like the USA that are at the forefront of innovation in that area?
I think politics, not necessarily politicians, is extremely important. It's part of that big picture, complex system slide I showed earlier, and the path dependency question. In other words, it's actually very difficult to dismantle health systems. So in the UK, and I don't know where you're all from, but those of you listening in from the UK, we have an election coming up. Lots of talk about the National Health Service and is it safe in the hands of the Conservative Party? It's actually very difficult to remodel the NHS in the UK because we have a particular view about how healthcare should be delivered. And whilst there is change at the margins, often what you find is that whenever there's an innovation brought in, and it may be a very, very evidence-based good idea, like rethinking where we deliver emergency care, and concentrating that in certain hospitals rather than trying to deliver it everywhere. You often get a political response. You get local MPs jumping up and down, saying, my constituents don't like this idea. We want our local hospital to still have an emergency department. So politics is very, very important, I think, in blocking change, but equally it can support change as well. And in the UK, we actually have a pretty good system now, I think, for funding and nurturing innovation in the health system from early startup stage through the pipeline, and a good understanding now of how healthcare providers and what they need to do to how they can better take up innovations, better than most countries actually, and that's been due to policies over the last 20 years. So politics, yes, very important. Trump, Bolsonaro will be a blip in the long term, I think. I don't know what Trump's policy on healthcare is actually, or Bolsonaro's. It'll be interesting to see.
Brilliant. Well, I think that's all we've got time for. Thank you, James, for all your insights. And thank you for everyone for joining the webinar today. And I hope you have a lovely afternoon. Bye.
Thank you.